Greetings. Today we are going to be talking about cellulitis, a very common medical condition that you will find in any environment. Once again, I am Major Frank Gonzalez and I am a doctor of family medicine by training. This presentation is going to be geared at the combat medic, corpsman, EMT, and paramedic level, but anyone can benefit from it. So if you are just curious to learn a little more about this, then stay tuned. Cellulitis is an infection of your skin caused by bacteria. Our skin, believe it or not, is the largest organ in our body and serves many purposes, to include regulating our temperature and serving to keep viruses, bacteria, and funguses out. Sometimes, however, bacteria can invade it, and we need to help our body a little bit in ridding the infection. I personally like to think of skin as being a brick wall, keeping bad things out. Whenever something gets past that outer layer of skin, or epidermis, and enters the deeper levels, it will almost always cause pain, swelling, redness, warmth, and discomfort, otherwise known as inflammation. When skin is healthy and hydrated, it's like a brand new brick wall. As you can see, it is not possible to view the other side of the wall, as all the bricks are intact and all the spaces between them are filled with mortar, so since there are no gaps, it's not possible for anything to pass through it. Looking at the healthy, glowing skin on the right, note that there are no cracks, fissures, or holes in it. The mortar of our skin is water, or hydration, and so healthy, moisturized skin is completely optimized to keep bad things out. Now, look at this brick wall. It's worn down, mortar is missing, there is a large hole in the middle. This wall is certainly not keeping anything out. Looking at the dry, cracked hand on the other side, though it doesn't have a hole through the middle of it, you can see where it's cracked and missing mortar as well, so to speak. Someone with this type of skin is much more at risk to develop an infection or some other cause of skin irritation. In keeping with the brick wall analogy, the bigger the hole in the wall, the easier and faster it is for things to pass through it. And if we are talking about the human body, that means infection. Therefore, in large deep wounds, like a gunshot wound, we give antibiotics much early on. Think of the combat pill pack, before there are even signs of infection, and why it's important to close the openings in your skin as soon as possible. What causes these cracks? Physical damage to the skin from a laceration or abrasion, or dry, cracked skin from excessive washing or from exposure to chemicals or fungal infection of the skin, to name a few, can all reduce the skin's ability to keep things out. There are millions of different bacteria in the world that can make a person feel sick or cause infections. Today we're going to talk about the two most common types of bacteria that cause cellulitis, those being Streptococcus pyogenes, also called group A strep, or just strep for short, being the most common, and followed by Staphylococcus aureus, or staph. Bacteria exist everywhere, so who's to say where we pick them up in the first place? Fun fact, a particularly nasty strain of staph colonizes or lives harmlessly in the nostrils of some human beings. In some people, it causes them to have frequent skin infections, but in others, it does nothing. Very odd. In any case, therefore, whenever you cut or scrape yourself on something, be sure to wash the area with soap and water in order to remove any potential sources of infection. Better 30 seconds of soap and water than 1 week of antibiotics and diarrhea. Why should we bother remembering these two strains of bacteria? Well, for one, they are fun facts to bring up at parties, but also this helps us to select the right antibiotic. In a moment, we are going to review some pictures of infections caused by staph and strep, and soon you will get a feel for what the infections they cause look like. Physicians, PAs, nurses, basically any kind of medical provider is essentially a highly educated bookie. Using a combination of details that we gather from the patient's history and the physical exam helps us to start creating the odds in our minds of what the diagnosis is, and therefore what the treatment is or should be. The only way to be 100% sure of what the bacteria is that is causing an infection is to grow it in a lab. However, that takes both a lab and at least 48 hours. Two things that I can assure you a combat medic does not have. So when we diagnose, we are basically making an educated guess. The genus of Streptococcus has several common strains that cause nasty symptoms in human beings. Aside from skin infections, other problems this bacteria cause include the famous strep throat, an ailment that affects many children, and can also cause rheumatic fever, a condition that can permanently damage your heart. So, needless to say, this bacteria gets around. Usually it doesn't cause abscesses, but depending on the strain, it can. However, all members of this family respond to my favorite antibiotic, cephalexin, otherwise known as Keflex. If there is one antibiotic that you should have in your kit bag, it's this one. It treats skin infections, sore throats, and urinary tract infections. It's effective, small, and cheap, and it can probably be used without a problem in people who have a very mild allergy to penicillin, like only getting hives. if you don't have an alternative readily available like clindamycin. This is typically what cellulitis caused by group A strep looks like. It will be very red, hot to the touch, very tender, and with a clear line of demarcation. The picture in the top right shows someone who traced the extent of the infection to track response to an antibiotic, but we'll get to that in a few slides. Staph. It is divided into two types based on their susceptibility to a particular antibiotic: methicillin-sensitive Staph aureus, or MSSA, and methicillin-resistant Staph aureus, MRSA or MRSA for short. Guess which is worse? Right, MRSA. Infections caused by staph usually cause a lot of pus to form or cause abscesses. This bacteria does not respond to cephalexin like strep, so we need to use doxycycline, or doxy for short, or trimethoprim sulfamethoxazole, also referred to as Bactrim. There are other antibiotics that can be used to treat either staph or strep. I'm just trying to name those meds that a medic should be carrying in their aid bag. Last, MRSA is much more likely to get into your bloodstream and cause sepsis than strep. So if you come across a soldier with fever, chills, and an infected wound, be sure you're giving an antibiotic that covers or treats staph, as the soldier is likely septic. Here are pictures of what infections caused by staph look like. Again, the thing that usually gives them away is that they have pus visible or coming out of them. Or maybe you can see pus beneath the skin, like in the bottom left pic. This is called fluctuance. If you remember the pics of the infections caused by strep, those just look like red skin, a little hard to the touch and without pus, or purulence as it is referred to in medicine. Let's discuss a practical case where we can put some of these details to work. Private Jones approaches you, the platoon medic, one morning while your platoon is set up in a patrol base, due to his complaints of a red, painful, tender rash on his leg that he is pretty sure grew overnight. He has not started any new medications, creams, ointments, etc., and does not recall having been bitten by anything. He also denies fever and chills. What do you do next? Obviously, you're going to look at and examine what's bothering him. If there is one golden rule in medicine is, if it hurts, touch it. Believe me, that has changed my diagnosis on more than one occasion. So you don some latex gloves, he raises his pants, and you see a well-demarcated area of redness on his leg that is noticeably much harder to touch than the normal appearing skin and feels a little hard to the touch. It's also tender and painful when you press on it. Pain to touch is an important clue that this is cellulitis. Things that are commonly mistaken for cellulitis that look almost identical but are not painful to touch will be something like contact dermatitis, which is basically an allergy to something that touches your skin. Though they look similar, a person with contact dermatitis will complain of itch and not pain and are treated in a completely different way. This is a key question to ask, so file that pearl away for later use. After examining his leg, you diagnose Private Jones with cellulitis. Next, we want to put in place a way to physically measure improvement and not just go off how the patient feels, though that is important too, so you will next trace the perimeter of the red and painful area with a black permanent marker and write in the date and time as to when you marked it. Next, assuming no allergies to penicillin, start him on cephalexin 1,000 milligrams twice daily for 7 days. Usually with antibiotics, it takes anywhere from 24 to 48 hours to start having an effect, and therefore any improvement to be noticeable. Now, it is not uncommon in this window, when the antibiotics are started, for the redness to creep a centimeter or so past the black line that you drew. So don't be alarmed, as that does not necessarily mean the antibiotics are ineffective. After 48 hours, you should be seeing improvement. Ideally, we are looking for the wound to be less painful to the touch or less red, as indicated by the affected area shrinking from the black line you drew. If you don't see any signs of improvement, then continue the cephalexin and add doxycycline, or Bactrim, and retrace the new perimeter of the redness, applying the new date-time group, and repeat inspection in 24 to 48 hours. Sometimes staph infections can look like strep early on before they formed any pus, so you may have just needed to broaden your coverage, or the infection is polymicrobial, meaning more than one bacteria, though you often don't see that in the population of people which we treat, which is military-aged men and women. If in 48 hours you are still not seeing improvement despite being on 2 antibiotics, then you need to contact a provider and or reassess what you think is going on. In a population of young healthy people where the wound remains red and painful to touch after 4 days of dual antibiotic therapy, this patient likely needs IV antibiotics and or hospitalization. The other possibility is that they develop an abscess that we have not yet identified. We haven't covered this yet, but abscesses greater than 2 centimeters do not respond to antibiotics and must be drained. So what finally happened to Private Jones? Well, being the high-speed medic you are, after having diagnosed him with cellulitis and having started him on cephalexin, 48 hours later, Private Jones feels significantly better, as can be seen by the universal sign of "I am fixed," the thumbs up. And after 5 days, there was no redness left, so great job with that. This slide is just a quick summary of the things that we talked about, so go ahead and take a couple of seconds, kind of read it over briefly. Examine the wound, trace the infected area. If no allergy to penicillin, start them on cephalexin. Re-eval the wound in 2 days. If it's not getting better, continue cephalexin and add doxycycline or Bactrim. If not better after 2 days of that, call a provider. So, common questions I hear. Doc, why not just start the person who you suspect has cellulitis on dual antibiotic therapy, cephalexin and doxy or cephalexin and Bactrim? The answer is you can totally do that. And if you are uncertain as to if this were strep or staph, then please do that. In medical terms, this is called impaired treatment or broad coverage. You are giving a treatment to treat several different causes at once. As you gain more experience, you'll have a better idea of which infections are safe to just start the person on one or the other antibiotics. Just remember that the more antibiotics you put someone on, the more side effects they are likely to get, like a rash, upset stomach, diarrhea, and in women, urinary tract infections or vaginal fungal infections. Alright, so a few slides ago I mentioned that one reason why someone might not be responding to antibiotics for their skin infection is because they formed an abscess. Let's talk about this. An abscess is really nothing more than a large pimple. All of us can remember fondly the days of high school spending a few minutes each day popping zits or pimples on our faces, and then the feeling of satisfaction that came as we squeezed all that pus out. There were those zits that had a white head, kind of like the picture in the middle, and those were easy to get rid of, but then there were some other pimples that didn't have the white head. They weren't ready yet. They were still too deep in the skin. Sometimes those would go away on their own, and other times you would have to wait a few days for it to be ready to burst. Abscesses that form on our body are just large pimples. Some are ready to pop from the get-go and usually self-resolve, but other times they remain deep to the skin, where no matter how hard you squeeze, there was no getting that pus out. In those cases, we need to create an opening to get the pus out. How do you know if there's an abscess present on physical exam? You want to look for fluctuants. The pictures on the left and right are good examples of this. If you look closely at those pictures, you can almost see the pus pressed against the surface of the skin. When you see that, there's a good chance that you will be successful in cutting the abscess open and draining it, or passing a large gauge needle into it and aspirating it inside. Other times you might not see the fluctuants, but you can feel like a water balloon type structure deep to the red skin. So here's a cross-section of an abscess. You can see the pocket of pus several millimeters beneath the skin. Do note that this picture simplifies the abscess pus pocket to being a perfect circle or sphere, where in many cases the abscess has an irregular shape to it. This animation is portraying how antibiotics work on an infection. Basically, the medicine floats around your blood and slowly begins to get deposited through your different tissues. In this slide, the white circle is an abscess and the blue circles represent antibiotic molecules. When the abscess is small, the antibiotic can penetrate to the core of the infection and kill all the bacteria inside, thus resolving the problem. However, when the abscess becomes larger than 2 centimeters, then the antibiotic cannot penetrate deep enough to kill the bacteria. To be more specific, what is actually happening is that the chemical conditions within the infection actually deactivate the antibiotic molecules as they penetrate deeper into it. That's why in this diagram, all the blue circles are on the periphery and none of them are in the center. If you can't drug them, cut them. If the antibiotics are being activated by the pus, logic would dictate you first remove the pus and then start the course of antibiotics. A previously widespread idea in medicine was that following the incision and drainage, or IND, of an abscess, it was not necessary to give antibiotics. However, for people who cannot maintain good hygiene/cleanliness while it heals, like soldiers in the field or in training, or are prone to developing abscesses, it would be a good idea to treat with doxycycline or Bactrim 5 to 7 days following drainage. This picture does a pretty good job of explaining pictorially how this procedure is done. I will be looking at adding a procedural video onto my YouTube channel soon for reference. The procedure is very easy to do and certainly within the scope of what a combat medic's practice is. Basically, working our way clockwise on the diagram, starting from the top left, shown here, you anesthetize the skin around the abscess. This technique is called a field block. Then wait about 10 minutes for the anesthetic to take effect. After that, you will cut through the roof of the abscess with a scalpel, usually a number 11 blade. If you don't have a scalpel handy, any blade will do, just make sure that it is clean. You will ensure that the cut extends the length of the suspected abscess. If you cut into the abscess, then you should start to see pus spill out of the wound. Squeeze as much pus as you can out. Next, you will probe the wound with hemostats or Q-tips, basically anything sterile that won't cut the person as you push it into the wound. And you're doing this in order to break up remaining collections of pus within it. These are called loculations. You can imagine the pus kind of forming little walls or little rooms within it that regardless of how hard you squeeze, if you don't break that wall down, you cannot get the pus out and therefore it will not heal. After you break up all these loculations, you squeeze even more pus out. You will then irrigate the remaining empty abscess cavity with saline or water. This helps to remove problematic bacteria from the cavity. Finally, in order to make sure that the abscess continues to drain and to prevent it from reforming, we would pack or fill the abscess cavity with sterile gauze. I usually use iodoform gauze or gauze that is infused with iodine, but 4x4s will do as well. You will need to change this packing every 1 to 2 days. And you'll note that as time passes, the cavity will accept less and less packing material. This is because the cavity is healing from the inside and growing smaller. This is exactly our goal in this process. In closing, cellulitis is an infection of the skin by bacteria and is generally caused by one of 2 different types, strep or staph. Both types will have skin that is red, hot, and tender to the touch, but staph commonly has pus and or abscesses. Always treat with cephalexin. The question will be whether you also add doxycycline or TMP/SMX, Bactrim. If you can't tell if there's an abscess or think that the abscess might be less than 2 centimeters, then start cephalexin plus one of the other 2 antibiotics. That covers staph. If the abscess is greater than 2 centimeters, it will not respond to antibiotics and must be drained. Since we are treating soldiers who will be going back to the field, start any person who was drained of an abscess on 7 days of doxy or Bactrim. This concludes my presentation. Thanks for your time and run the line.